Okay, here we go, folks. I'm setting up for another lecture. Hopefully this will work out. Okay, let's go back a slide. We're doing response to illness and legal today. Let me get this aligned, and I think we are good. All righty. Let's see. So the question here is, what causes some people to survive tragedy and others to become ill? In other words, some people can just endure a lot of discomfort and illness and still have a positive attitude. What causes some people to want to fight against illness and others to give up? We've talked about the answers to this already, but we'll go into it again now. Okay, here it is. Response to stress and illness influenced by two basic factors. Genetic predispositions. Are you more prone to depression? Are you more prone to anxiety? If you are more prone to those disorders than others, you're probably going to have a less positive reaction to other illnesses. Whether those illnesses are psychological or physical, it doesn't really matter. Environmental factors. As a general rule, the greater the stressor, the less genetic influence is needed. So genetics plays two roles here. It has a role in acquiring the illness itself and how you react to the illness in terms of your resiliency or hardiness. So again, as a general rule, the greater the stressor, the greater the environmental trigger, the less genetic influence you need. If your family has oncogenes, genes for cancer, and you smoke cigarettes, there's a greater chance that you will have cancer from smoking cigarettes versus a person who has no cancer genes in their family, no history of cancer. If they smoke, they probably have a less of a chance of getting cancer. Okay? The greater the genetic load, the less stress needed to get ill. And again, this holds true for mental disorders. Mental disorders, like most other physical disorders, are an interaction between genes and the environment. As I've said before, for lack of a better analogy, genetics loads the gun and the environment pulls the trigger. Earlier the onset, the poorer the prognosis. So generally with most disorders, whether they're physical or psychological, the younger you are when you get them, the prognosis is probably worse as a general rule. If you have diabetes at the age of 1 year old, you have a much longer life to live, so it's going to have a greater impact on your life versus if you have diabetes at 80 years old, you probably only have maybe 10 years or so to live, so it's going to have less of an impact. Genetic influences. Genes play a great role in both susceptibility to illness and the course of illness itself. If a person has a family history, as I just said, smokes cancer and smokes cigarettes, greater chance that they will get cancer. If a person has a family history of anxiety or depression and is then sent to Vietnam, they're probably more prone to PTSD. And again, it doesn't have to be Vietnam. It can be a car accident. It could be any kind of trauma. Again, these genetic predispositions really come down to neurotransmitters. Okay? Neurotransmitter imbalances or receptor defects. So let's talk about receptor defects a little bit. And maybe I shouldn't call them defects. They're probably better called alterations. You could have the proper level of neurotransmitters, but your receptor reacts differently to it, or they don't react at all, or they react not quite enough. In fact, type 2 diabetes is just that, is that you have the proper level of insulin, but your receptors are not reacting to it. Okay, back to psychology here. In terms of anxiety, we've learned about this, I think, already. You might not have enough GABA, not enough serotonin, maybe too much adrenaline, maybe too much dopamine. Remember, adrenaline and dopamine are activating neurotransmitters. They turn on your nervous system, and this is what coffee does. Again, drink too much coffee, tend to get anxious. In terms of psychosis, possibly too much dopamine. How do we know that? We know that two ways. We know that when people do stimulants, and this was noted during World War II, when pilots and the crew took stimulants to fly 1,000 miles, drop their bombs, fly 1,000 miles back, some of them, the crew, was coming back with paranoid ideation, paranoid thoughts. We also know that antipsychotics block the effect of dopamine by binding to the dopamine receptor. And we notice when that happens, paranoid psychosis goes down. Okay? You also may have too much serotonin. Too much serotonin, as we learned in the drug lecture, can induce visual hallucinations. That's literally what LSD does. It jacks up your serotonin so high that you begin to see things. To depression now, we know not enough serotonin. How do we know that? We know that because when we give somebody an SSRI, a selective serotonin reuptake inhibitor, that blocks the reuptake of the serotonin into the presynaptic nerve. If we block the reuptake, more's in the synapse, more hits the receptor on the postsynaptic nerve, and the person's mood is elevated. And if you remember from anxiety lecture, their anxiety goes down. And let me just reiterate something. The best treatment for long-term chronic anxiety is an SSRI, probably Paxil, Zoloft, or Lexapro. Well, maybe with depression you don't have enough adrenaline. We know that caffeine indirectly elevates adrenaline, dopamine, has mood-elevating properties. Maybe not enough dopamine. The medication bupropion, Wellbutrin, blocks the reuptake of dopamine and norepinephrine. So when you elevate those neurotransmitters, you can reduce depression. There are many different neurotransmitters and hormones that can govern mental health and how we respond to stress. I just want to discuss for a second what is the difference between a neurotransmitter and a hormone. Neurotransmitters communicate between nerve cells, so they are very isolated in the nervous system. A hormone is global. It's systemic. It goes all over your body. Okay, the hormone adrenaline causes the release of cortisol, glycogen, things like that to get ready for fight or flight. So the difference being is a neurotransmitter is at the synaptic space, at the nervous system, and a hormone is released, probably in the case of adrenaline, the adrenal gland, and it is systemic. It's all over the body system. The human mind has evolved a delicate balance of these neurotransmitters. I've heard it called an exquisite balance that through evolution, survival of the fittest, natural selection, people with the optimal neurotransmitters to survive and have good judgment have enough pleasure not to harm themselves, but not to have so much pleasure that they lose judgment. In fact, that so much pleasure and loss of judgment could be considered bipolar manic phase. Areas of the brain that are damaged or poorly developed can also cause mental illnesses or affect how we respond to stress. Antisocial personality disorder, as I've heard in the past, could very well be the part of the brain that takes in norms and morals of society is underdeveloped. So again, this is nobody's fault. This is something going on with the brain not functioning optimally. Environmental factors affecting how we respond to illness. Past environmental factors. How was illness or stress dealt with in the family group of origin? Again, the first group you're in is your family, and I've probably said this in class. The role you take in your family will probably be a role you take on later on in life. Okay? So how did your family deal with illness? Did they collapse emotionally, or did they rise up and address the issues logically in front of them? What is the current environmental factors at time of illness or stressor? Is person in good physical or mental health? In other words, if you're in good physical health and good mental health, you can deal with more stressors coming at you, as opposed to if you already have depression or diabetes possibly, stressors are going to affect you more greatly. Interpersonal environmental factors, social supports. We know that the human being is the most social animal on the face of the earth. How do I know? Everybody's got a cell phone. We want to communicate. In fact, that is one of the biggest problems with this quarantine that we're in now from COVID, is that we can't communicate with other humans. We're home with our family, which is wonderful, but we want to go and talk to people and play golf and go bowling, and we can't socialize. So it makes us anxious. In addition, back to COVID, the ambiguity of when will this end? Will I get sick? The ambiguity creates anxiety. As I said in one of our first lectures, a mentally healthy human being can tolerate ambiguity. Everybody is feeling ambiguity now because we don't know enough about this virus to give any definitive facts. Okay. So again, If you're well connected and have a good social network, a supporting significant other, chances are you're going to deal better with life stressors than people that don't have social supports. And again, that goes along with physical illness also. Other life events occurring at the time of the stressor. If you have multiple stresses at once, chances are the prognosis will be worse. If your family, your wife, your children are killed in a car accident, as opposed to someone's father dying, when you lose many, many people at once, chances are it's going to be more difficult to deal with. Cultural and spirituality, how one's culture views illness. Does person have supportive culture or religion? So in your culture, the illness you have or something you did, does your culture accept that? Okay, or does your culture say, no, we don't accept that, which means you can't speak to anybody in your culture because they'll reject you. I've often posed the question in lecture, who do we call for this? This is a time for a therapist, a neutral therapist that can hear you, let you emote, let you verbalize your feelings without judging you. That lack of judgment is called neutrality. So having someone to listen to you and not judge you is a very wonderful thing, and we can thank Sigmund Freud for that. Developmental age and stage. Developmental stage, are you in, what stage are you in at the time of the trauma or illness can affect the way you respond to trauma. Okay, I'm just making sure I have this all in here. I think this is good, right? Prognosis. Okay. So if a boy, a 12 or a young boy tries to mow the lawn and he cuts his foot with a lawnmower, that's going to have a greater effect as a 45-year-old man who mows the lawn and cuts his foot with a lawnmower. Because a boy is trying to be a man. And if we look at a 12-year-old boy in this picture, that's Erickson's industry versus inferiority. The child, the boy here, is trying to be industrious like daddy. But he fails at that, and now he has inferiority. He didn't raise to the task of becoming a man. Again, talking to a therapist can help resolve this. Chronological age can also affect prognosis. As I said, early onset schizophrenia has a poorer prognosis than if you get psychosis later on in life. Hardiness, the ability to resist illness even though exposed to stressors. A good example of this is a plant that can resist drought. Resilience, on the other hand, these are healthy responses to risky or stressful situations, and this seems to be related to self-esteem and self-efficacy. What is self-efficacy? Self-efficacy is the ability to solve your own problems. You feel efficient at solving your problems. You can handle this. Nursing school, in a sense, is a preparation to getting you ready for you to work on a high-pressure nursing floor. Nursing school is stressful. You learn how to deal with that stress, how to organize information, because nurses deal with a lot of information coming at them at once and learn what to prioritize on and what not to worry about. What I've always learned in my career is I worry about what I'm responsible for in my tour, my 12-hour or 8-hour tour. I don't have to worry about what we need to do a month or a couple of weeks down the road. Okay, so stick with what you have to do during your tour. Our job is to assist the client in developing positive self-esteem and a sense of self-efficacy by teaching client how to solve their own problems. This is the goal of all healthcare now. It used to be that the doctor or the nurses took care of people's health care. Nowadays, we want to educate people about their illness and how to treat themselves. We teach the diabetic how to take their own blood sugar. Certain blood sugar levels get a certain level of insulin injection. Okay, so the goal now is to have people be able to manage their own illness. Of course, if you need your doctor, you can go there, but to learn how to do it on your own. That is self-efficacy. Okay, and our job is to help people get that. A good example of that would be a patient coming up to the desk asking for an Ativan for anxiety. If I give someone an Ativan, what I teach them is you can't handle your own problems. You need to take this pill forever. On the other hand, if I say, Mr. So-and-so, why don't we sit down and talk a little bit and discuss what's bothering them, what I have found is about 90% of the time, if you give a patient 10 or 15 or 20 minutes of undivided attention, validating what you're hearing, helping them organize their thoughts, they don't need that Ativan. If they do, we'll give it to them. But we don't just give people a benzo to get them out of anxiety. Okay, we want to help them work through it, because if we give them a benzo every time, basically what we're doing is we're telling them they can't solve their own problems, and we could be creating someone that becomes drug dependent. When we teach them how to think it through, talk about their emotions and their problems, we teach them, one, they can tolerate this anxiety a little bit more, two, that they can manage their own problems. Okay. Through successful problem solving, one gains confidence, self-esteem, and self-efficacy. Mental illness, as I've said before, is on a continuum defined by degree, how severe, and duration, how long. And many of the illnesses in the DSM are based on how long do you have it. If you may remember from depression, you must have these severe symptoms for 2 weeks or more. So you can wake up feeling terrible one day. Oh, I don't want to get out of bed. Life is not worth living. You go to sleep, you stay in bed, you wake up the next day, and you feel better. You wouldn't meet the criteria for depression. Most of us will have some type of mental illness in our lifetimes. This does not make us inferior, it makes us human. The human condition is defined by emotions, ups and downs, stressors, things like that. Humans are the smartest animal on the face of the earth. We're the only animal that builds houses. Yes, beavers build a little house in a pond, that's true. But they don't build houses like ours. They don't send men to the moon. Okay? We are very smart, but we are very, very emotional creatures. The question now comes, I will ask you, what is the purpose of emotions? I believe that the purpose of emotions is probably to help manage and educate children. If you tell your child in a very mundane voice, don't cross the road, yes, they may hear the words, but they don't hear the affect. If you say, on the other hand, don't cross the road, with some emotional tone to it, the message is clearer. I should not cross the road. So I believe emotions have to do with communication, probably raising children. Let's talk about culture. What is culture? Culture is a set of shared beliefs, patterns of behavior, values, and attitudes learned through socialization. We can learn a lot about cultures, and we should know the basics of cultures, but you cannot apply the culture to the individual. That is called stereotyping. So again, we should know some basics, but what we really have to do is, upon admission, ask the person, is there anything we can do for you regarding your culture? Maybe if they're Orthodox Jewish, they don't eat pork, or Muslims don't eat pork also if they're Orthodox. So we simply ask them on admission how we can meet their cultural needs. America used to be called, and is sometimes called, a melting pot. I think a better definition that I heard from David Dinkins, the ex-mayor of New York City, about 30 years ago, America is better defined as a mosaic. What does that mean? A melting pot means that all the cultures get mixed together. But people with certain cultures in America want to retain their cultural heritage. Italians, Puerto Ricans, Germans, they want to retain their culture. So I think a mosaic, and a mosaic is a picture painted with a lot of little pieces. That's what a mosaic is in terms of art. So I think a better definition is a mosaic. USA used to be called a melting pot. This is what I just said. Culture can be diluted depending upon length of time out of culture of origin. So we cannot assume if someone has a vowel at the end of their last name, Mangino, that they are all Italian or they love garlic. Okay? We can't make that assumption because people acculturate. They assimilate into the dominant culture that they're in. Okay? Our government and all governments want their culture to be seen as the best culture. That's called ethnocentrism. but all cultures have equal value. All countries and cultures of the world offer something to the world. In fact, we can truly say that America is a mixture of many, many, many cultures. That is the beauty of America. It's the whole world in one country. Okay. This sense of ethnocentrism really creates national pride and patriotism. And we should have that, but we should also realize that other cultures have value. We as health professionals must unfreeze ourselves to be open to other cultures, and that's really neutrality. We're not going to say that our culture is the best. Okay. Cultural view of mental illness. European American. European Americans, and America tends to be a European country, although it's changing, tended to view mental illness as weakness. Okay, this would be 40s, 50s, 60s, maybe 70s, or they did it to themselves. The drug addict did it to themselves. We now realize, and Prozac had a big impetus here, that mental illness is, no one causes that. It is genetic. But what happened with Prozac is it was an antidepressant with so few side effects that you could give somebody that had a minor depression or a mild depression this Prozac, an SSRI, the first SSRI, and their symptoms went away. So many people were being put on this wonderful drug Prozac for mild symptoms, and that opened up people's mind to talking about depression and anxiety, things like that. Prior to the SSRIs, you might remember, we had tricyclic antidepressants, which had a lot of side effects: constipation, can't see, can't pee, can't spit, you know that. Monoamine oxidase inhibitor, that you couldn't eat certain foods. So Prozac, the first SSRI, really revolutionized healthcare, particularly of depression. Okay, let's talk about Hispanics. They may believe, and I write may because we can't assume that every Hispanic feels the same way, okay, may believe illness is caused by bad spirits. African Americans may believe mental illness is due to spiritual distress or lack of spiritual balance. Asian Americans tends to be a stigma of mental illness. Again, we can't assume, we cannot apply this to the group. Tend to blame on something physical. That would be called somatization. If you remember, the word soma means body, I believe, in Greek. May believe it's caused by a metabolic imbalance, and they may not seek mental health treatment until the patient is very ill. Of course, that makes our job a little more difficult, because the longer somebody stays with a mental disorder, the more entrenched it becomes in them, the more it becomes part of their personality. So it becomes more difficult to treat. Not that it can't be treated, but it gets a little more crystallized. American Indians may believe that mental illness is caused by a curse placed by someone else. I know the Italians used to talk about the cursatore, putting a curse upon somebody. Let's talk about Islam a little bit. And Islam is not a violent faith. It's a religion similar to Christian and Jewish faiths. Abraham is the father of all these three faiths. In Islam, the elderly man is most respected, more apt to take advice from men, not women, may feel mental illness is caused by supernatural forces. So Islam is not violent, and I'm thinking about 9/11 now. Those were people that said they were Islam, but they weren't being peaceful. Let us not forget that the Ku Klux Klan was made up of so-called Christians. So even Christians in this country can have extremists. We cannot know every culture or how acculturated someone is into American culture. We must therefore be respectful and accepting. We should ask the patient for any important traditions during the initial nursing assessment. Again, dietary preferences, things like that. One of the simplest things we can do in terms of communication, nonverbal communication, is mirroring, reflecting back to the patient their affect. Again, affect is how you present your mood. We return a gentle handshake with a gentle handshake, eye contact with eye contact. Some cultures, Asian cultures in particular, tend to make less eye contact. We don't want to stare them down, so we mirror back the way they're communicating with us, we communicate with them. Spirituality, common amongst all cultures, probably related to our deep quest for meaning in life. which is related to our highly developed frontal and prefrontal lobe. Again, what's very interesting that if you start at the base of the brain is the reptilian brain. The further you go up physically in the brain, all the way to the frontal lobe, which is above your eyes, the more advanced the function of that part of the brain. I find that fascinating. Okay. Religion is formalized spirituality. Everybody is spiritual to some degree. I think every human being sometime in their life has said to themselves, how did I get here? Why was I born? Why not someone else born? What am I doing here and where am I going? If you remember, one of our first lectures talked about that. That really is the ultimate ambiguity of life. Ambiguity meaning not clear, vague. We can't figure it out. Again, that's the problem with the COVID virus, that we can't figure it out, although we're doing that quite rapidly. Individuals have a varying degrees of need for spirituality. Some people are more spiritual than others. Okay? The need for spirituality generally goes up when people are in distress. There's a saying, there are no atheists in a foxhole. You might not believe in God when you join the military, but when you're in a foxhole and the bullets are flying by your head, you will pray to God that you survive. And that's literally what we're doing now during this COVID thing. We're all at home in our foxholes, protecting ourselves from getting this virus. The need for spirituality goes up. Yesterday was Easter Sunday. The need for spirituality goes up when people are in distress. If patient in spiritual distress, we must try and help ourselves or call in someone else who can. That would be clergy, a priest, a rabbi, to call them in and help that person with their spiritual distress. Okay, so nurses, we're the central profession in the hospital, and we call in reinforcements as needed. It could be clergy, it could be a respiratory therapist, whatever is needed. Nurses have the greatest patient contact than any other health professional. And with that comes the responsibility to call in experts when we don't know enough about that area. Okay, cultural competence conclusion. Nurses should have a general idea of cultural and spiritual differences amongst people. It is impossible and presumptive to think we can understand all cultures thoroughly. Therefore, we act humbly, respectfully, and perceptively to the patient's needs. And again, we ask them upon admission. If we are unsure, we can simply ask the patient about their preferences. Okay, change of subject now. I think we're still doing quite well here. Legal and ethical issues in nursing or in any healthcare. Prior to the 1960s, mental health patients had very few rights. When you went into a mental institution in probably the 30s, 40s, 50s, you lost many, many rights. In those days, you were considered subhuman. We now realize these are genetic illnesses that nobody asks for. No one did anything wrong to cause a mental disorder. Once in a mental institution, it was very hard to get discharged. Civil rights movement began to apply to patients. Okay, in the late 60s, civil rights was a big issue in America. Okay, and that parlayed over to the rights of people in mental institutions. Psychiatric clients, as of now, retain all rights of any other American. They can get visitors, they can get mail, they have a right to see an attorney, they can enter into contracts, they're allowed to be on the phone, things like that. So the only right they lose is the right to leave the hospital if they're admitted involuntarily, the right to leave the hospital when they want. And again, we do know even with voluntary, they have to submit a 72-hour letter. So they retain every right except the right to leave the hospital when they want. And that's because we have a responsibility as healthcare professionals, the doctor in particular, when this person could harm themselves or others, we have an obligation to take care of them. And we as nurses need to explain that to the patient. I've told many a patient, our job is to love you until you can learn to love yourself, to protect you against yourself, to protect you from harming somebody else. Okay. Patient Bill of Rights, I'm not going to read them all. They're posted on every wall in the hospital, or in every hospital somewhere you'll find them. I know the students that have been to ELIH, I've seen them on the walls there, and other students have probably seen them in other clinicals also. People have a right, patients have a right to respectful, confidential, and non-discriminatory care. They have a right for information concerning their diagnosis, treatment, and prognosis. Our job with the doctor, or along with the doctor, is to educate the patient about their illness. Again, we're not going to give the patient information that's going to blow them out of the water and make them more upset. So we want to give them enough information where they can comprehend it, so they understand it, but not so much that we're going to make them more anxious. And it's generally the doctor that does this, just so you know that. A patient has a right, and actually in mental health care, it's very, very important that a patient is involved in their plan of care. Because again, if you have a patient that doesn't agree with the care plan that you created for him, you get the doctor gets the person stable in the hospital, but the person doesn't believe they need to be on meds, and that would be a lack of education from the nurse. They take the meds after they get discharged and throw them down the toilet. All the work you did over that month will have to start all over again. So it's very important in the mental health field that the patient is on board with their treatment plan, that they are involved in creating their treatment plan, that they agree with the interventions, the medical interventions, the nursing interventions that will help get them well. They have a right to refuse treatment or research unless acute threat to self or others. So there's 3 reasons why people get admitted to the hospital, the psychiatric unit: homicidal, suicidal, or gravely disabled. Well, we know what homicidal is, killing someone else. Suicidal is killing yourself. Gravely disabled means, in the clinician's judgment, they feel that your judgment, the patient's judgment, is so off that they may do something that might harm them. For example, someone in a manic phase, type 1 mania, might think they're a great swimmer and might tell the doctor, I'm going to swim from Greenport, Long Island to Connecticut. Well, that's a 20-mile swim. You'd have to be a very, very, very good swimmer to do that. So the doctor would say, no, I can't release you if you tell him you're going to jump in the water right now and try to swim to Connecticut. Okay? Gravely disabled. Okay. If refused mental health care, still eligible for medical care. So they have a right to refuse mental health care, and if they do, they still get medical care. The only person that can mandate that a person take medication is a judge. So a patient can refuse continuing medication. They can say, no, I'm not taking the Abilify or the Seroquel. I refuse to. What will probably happen then is the doctor will take the patient to court. These courts are on the grounds of Pilgrim State. A judge will hear both sides and determine whether this person, when they don't take their meds, if they're not violent, the judge may release them. On the other hand, if they have a history of violence when they don't take their medicine, the judge may say, Mr. So-and-so or Mrs. So-and-so, I'm asking you to go back to the hospital and take your medicine as the team is asking you to do. And what I have found is they do just that. They go back to the hospital and they take their meds. But we as nurses, mental health professionals, if we can get that patient to take their meds and avoid having the doctor take them to court, we've saved the hospital a tremendous amount of money. Let's think about this. You have to take a patient from the hospital to Pilgrim State. You get the van from the hospital. You need the doctor. You need an RN. You probably need 1 or 2 nurses' aides to protect the patient from jumping out of the vehicle, something like that. So you need 3, 4, or 5 people. You need a driver of the van also to take this person to Pilgrim State. That whole thing takes about 4 hours. So we're talking $2,000 probably to take somebody to court. So if we have a psychiatric nurse that can educate this patient about the benefits of taking their medication or other forms of treatment that might be prescribed, the doctor does not have to take them to court, and we save a lot of money, and the patient gets well quicker. What I have done in my career is patients say, I'm not taking that med. No way, I'm not taking it. I won't take it. Mr. So-and-so, why don't you try it for a week? If you don't like it after a week, tell the doctor you don't want to take it. Okay, Mike, I'm just going to take it for a week and that's it. Okay, just try it for a week. And then what happens at about the end of that week, the medicine begins to work, whether it's an antidepressant or an antipsychotic. In the case of antidepressants, the person's mood is coming up; they're feeling better. In terms of antipsychotics, they're less having thoughts of violence or harm or paranoia. They feel better. So what I have found is they take it for a week or so, they begin to feel better, and then they say, okay, I'll take it. I do feel better. So through education, we can get cooperation. In fact, one of my mottos is, through education and explanation, we tend to get cooperation. So what does that mean? That means we give the patient, the rationale, the reason why this medicine is going to help them. Not because I say so, because of science and the evidence behind that medicine. All medicine is proven to be safe and effective. It must be proven to be safe and effective before the FDA lets it go to market. Okay. If refused mental health care, still eligible for medical care, and they have a right to see their medical records. Years ago, 20, 30, 40 years ago, patients did not look at their medical records. Nowadays, patients have a complete legal right to see their medical records. In fact, they can write in their chart, I am not a schizophrenic. So, on that note, we always want to document very clearly and objectively. We only document facts, not emotions, not feelings, just the facts of the situation. And if the patient wants to read them, they can read them. I've had patients read their charts, and I say, whatever's written in this chart is, we're just writing down how you're doing. Oh, can I read it? The patient reads the chart. Mr. So-and-so is watching TV, playing cards with peers. Oh, okay. I guess you're right. It's just what I did last night. Again, there's no trickery in mental health. And many patients feel, especially if they're new to the hospital, that the team in the hospital is out to trick them. We're not out to trick them at all. Our only goal is to give them a better life. I've told many a patient, I want to see you on the golf course, not in this unit. If you need to be here, that's fine. But I want to see you on the golf course having a wonderful day and a wonderful life. They have a right to know the credentials of their caretakers, who's the MD, who's the LPN, who's the RN, who's the physical therapist. They have a right to know hospital policies which affect care, potential conflicts of interest. If the doctor is giving them Abilify and the doctor is doing a study with Abilify, the patient has a right to know that. They also have a right to know, does the hospital invest in stocks that are mental health care stocks? Eli Lilly invented Prozac. If a hospital or doctor is invested heavily in Eli Lilly's stock market, the patient should know that, okay, because it could be seen as a conflict of interest. Okay. Aware of a grievance protocol, able to sue for negligence. So patients, there is a whole protocol where a patient can grieve their care if they feel they were treated unjustly. Hospitals have what's called a patient rep or an ombudsman, and this person is there to talk to the patient if the patient is feeling they're being mistreated. It can happen quite commonly on a psychiatric unit. If you get someone who's in a bipolar manic phase and they believe that they're president of the United States or maybe Jesus Christ, and they feel that you shouldn't be putting Jesus Christ on a locked ward and they're going to sue everybody, this is not right, we can say, would you like to speak to the patient rep? We call the patient rep up. Again, you as the nurse, you followed policy and protocol. You've done nothing wrong. The patient rep comes up, talks to the patient, talks to you, goes back to the patient. And usually what happens is, again, I work evenings, is the patient rep will tell the patient, the nurse here cannot control your discharge. The doctor is in charge of discharging you and your treatment here. The doctor will be in tomorrow, So I, the patient rep, are asking you, the patient, to wait until tomorrow to talk to the doctor about discharge. The nurse here does not have that power. She cannot discharge you. Okay. And again, the patients have the right to least restrictive means of care. In other words, we don't want to never put them in seclusion for not taking their meds. The least restrictive means necessary to help manage behavior. Okay? And again, seclusion and restraint is only used for protection of the patient and others around the patient. This is not a complete list of the Bill of Rights, but it's some of the big ones I've included. Any restrictions on freedoms can only be made by an LIP, that would be a nurse practitioner, or a physician, or a judge, with justified and documented proof. For example, we may tell a patient, Mr. So-and-so or Mrs. So-and-so, we're putting you on a 24-hour phone ban because yesterday when you were on the phone, after you hung up the phone with your wife, you put your fist through the wall, you broke your hand. We're going to limit your phone access, not to punish the patient, to have the patient concentrate on their own recovery. So, Mr. So-and-so, we're not doing this for punishment, but we want you to focus on yourself for now. We want you to get well here. Okay. Only a judge can make patient take continuing meds unless an emergency, such as very threatening behavior. So like I said a few minutes ago, a patient can refuse to take medication, continuing meds, daily meds, can refuse to take it. If the patient doesn't take those meds and they lose control with anger, if we have an order, we must have an order, can give an emergency medication against the patient's will. Of course, you would not do this on your own because chances are at this point the patient is very, very agitated. You would have to get a manpower call, 5, 6, 7, 8, 9, 10 people, women, men, policemen, to come in and give the patient this medication. AOT is assisted outpatient treatment. It's by court order. The patient is mandated to take their meds, probably because in the past when the patient didn't take their meds, they became violent. There's a law called Kendra's Law. Patient can be forced into some form of treatment if history of violence when not being treated. So Kendra's Law generally refers to medication, or could mean the person's going to be brought into the hospital for treatment. Okay, there's actually the ACT team, Assertive Community Treatment. This is a team of nurses and doctors that go to people's homes to give them the medication generally on a monthly basis. Okay, and the Kendra was, I believe, a woman who was pushed onto a subway, in front of a subway, by a patient who did not take their medication. Ever since then, there's a law in New York State, Kendra's Law, that can mandate that a patient must take medicine, be given medicine against their will, if they have a history of violence when they don't take their medicine. Types of admissions. There are many types of admissions, but I'm going into two basic types. Voluntary admission. Patient voluntarily admits themselves, needs assessment by the MD to verify the need for admission. So a patient just can't come to the ER and say, I want to go onto the psych ward. Okay, go ahead. No, they must be interviewed by the nurse practitioner, the psychiatric nurse practitioner, and or the MD, who verifies the need for that admission. They can request to leave. That person gets on the unit, and I've seen this happen. There's no smoking in hospitals. Okay, so they come in voluntarily. The doctor concurs, yes, you can benefit from hospitalization. They get up to the unit. They say, I want to smoke a cigarette. And we say, there's no smoking here. And they say, okay, I want to leave right now. And we say, but you can't. And they say, well, I came in voluntarily. Why can't I leave voluntarily? Because the doctor had to corroborate the need for you to be admitted. So what the patient does is the patient writes what's called a 72-hour letter. We simply give the patient a piece of paper, blank piece of paper, date it, time it, write, I, Mr. So-and-so, want to be released from this hospital. Sign it. Next time we see the doctor, we give it to the doctor. He reads it. And what does that mean? That means that that 72-hour letter gives the physician and the hospital staff 3 days, 72 hours, to assess that patient, to either keep that patient against their will or discharge them. Because it's hard to get a clear clinical picture in psychiatry of how a patient's doing in a 20-minute interview. Again, we are somewhat handicapped in mental health care. We have no lab values, we have no x-rays, we have no MRIs. So most of the data we get is by what the patient says, observation, and past history of behavior. And again, we need 3 days to observe you. Okay? If MD concurs, patient may get discharged AMA against medical advice. Okay, patient so-and-so, I will discharge you. I think you really should stay here, but I will discharge you against medical advice, meaning we are not responsible if something happens to you, and the patient has to sign that. On the other hand, if a good psychiatric nurse can come in there and educate the patient on the benefits of being admitted, for example, as I've told patients, what we can do in a psychiatric unit in 2 weeks might take them 2 months on the outside. Why? Because we're observing them all the time. We can adjust meds more quickly. Usually as an outpatient, you come in once a month or once a week. But if we see the patient 24/7 for 2 weeks straight, we can get clearer data on that patient. So I've told patients, look, we can get you well faster here. If you leave here, you'll see your doctor once a week or once a month. It's going to take him longer to get the right meds. So if you stay here, we can get you feeling better quicker. Once again, through education and explanation, we tend to get cooperation. If MD feels patient threat to self or others, MD will make patient involuntary. So now they're switched from voluntary to involuntary. Patient will be appointed a lawyer, a court date to contest the MD decision. So not only can the doctor take the patient to court, the patient can take the doctor to court, and a judge adjudicates if this patient can be discharged without treatment. But again, a good psych nurse can avoid that. Involuntary admission or commitment. Patient is admitted against their will because they are suicidal, homicidal, or gravely disabled. Can refuse treatment and take hospital to court, like I said. So again, we cannot force a patient to take medicine. The only time we can do that is when they're losing control and threatening us or other patients. Again, we'd have to have an order, and that medicine tends to be Haldol and Ativan mixed together in an IM injection. Let's see what we got here. I think we are done. Oh, wait, hold on, we're not done. Let's talk a little bit about confidentiality. Okay, we all know about HIPAA. HIPAA was a series of big laws that came through Congress. The part that we're concerned about is confidentiality. In fact, HIPAA stands for Health Insurance Portability and Accountability Act, so it talked about the portability of health insurance. But again, we are most concerned about confidentiality because the federal government realized with the onset of the internet, you could press send and publish someone's medical records around the world in an instant. So the federal government came up with laws protecting PHI, personal health information. Mental health restrictions are more strict. There's not much of a stigma with a broken leg. There is a stigma with schizophrenia, bipolar, and drug addiction. So there are more restrictions on confidentiality when it comes to mental health. I believe I read the first malicious offense of HIPAA can be up to a $25,000 fine. We don't want that. If requested to give information about a patient, say you are not allowed to do this as per federal law. You may get a phone call. If on phone, simply say, I can neither confirm nor deny that the patient is here and refer to the administrator. As I understand it, you get a phone call at the desk. Is my husband there? I can neither confirm nor deny that. Let me send you down to administration. Administration, as I understand it, can say your husband is a patient in this hospital, but we cannot tell you what unit he's on. That would make sense, because if a loved one is searching for their husband or boyfriend or girlfriend and no one can reveal that they're in a hospital, the cops can be looking. Meanwhile, the person's right down the street in the hospital. So as I understand it, they can say you're in the hospital, but not what unit you're on. So, or put patient on hold, or put the person on hold. We can, if we get a phone call, is my husband there? Hold on, I got another phone call, put them on hold, go down the hall, talk to this person. A woman is on the phone. She says she's your wife. Would you like to speak to her? If he says yes, you can give the wife the payphone number. Every psychiatric unit I've been on has a payphone where patients can call in and out. Okay. We can, consents can be signed, what's called a release of information, where someone, a patient, signs a release of information that gives us permission to talk to someone they designate. Those are time specific. So you don't sign a consent, and that's good for the rest of your life. It is time specific. Let me just get a sip of water because my mouth is getting dry. Excuse me, it's coffee. I'll talk quicker. Okay. So consents must be signed by patient to release information. Let's talk about privileged communication. So privileged communication means what goes on between a priest and a patient, a priest and a parishioner, a lawyer and a client, a doctor and a client. It's called privilege. Means it does not have to be revealed in court. In fact, it can't be revealed in court. It is communication that is protected by law, meaning it cannot be revealed in a court of law. An example, again, between a lawyer and a client, husband and wife. Husband and wife also have what's called privileged communication. Okay, we've spoken about confidentiality as per HIPAA. I think we're all well aware of that. But let's talk about some exceptions to confidentiality. It excludes child abuse, abuse of an impaired adult, elderly abuse, domestic violence, tracking STDs, prevention of a serious crime, for example, murder. So there are exceptions where confidentiality stops. Okay, we're going to talk about a very specific case in just a few slides. Okay, we spoke about consent and release of information. Only a client can waive privileged communication by signing a release or a consent. Consents are data, person, and location specific. In other words, the data being just referencing to this hospitalization, not about everything in the past and not about everything the patient has said to their therapist. Okay, duty to warn. If a patient threatens, makes a clear and credible threat, the mental health professional has an obligation, a duty to warn the person who's being threatened, or call the police and they will warn that person. Okay. Mental health professional has a legal obligation to warn any person of a clear and credible threat made against them. There's a case called the Tarasov case. This was a case in about 1976 or so. There was girlfriend and boyfriend. Girlfriend broke up with boyfriend. Boyfriend got very depressed, went to see a therapist, expressed to his therapist that he wanted to kill his girlfriend. The therapist could not breach confidentiality, and there was no law mandating that this therapist should be telling the victim, potential victim, or telling the police. The therapist did not do that. The patient, a male patient, killed his ex-girlfriend. It went to court, and basically what came out of that was privileged communication ends where public peril begins. So, if a patient is telling us that they are going to murder their girlfriend, boyfriend, policeman in a clear and credible threat, in other words, how would you do it? I just bought a gun. Well, when are you going to do it? I get out of here tomorrow at 12 noon. My girlfriend gets off of work at 12:30. I'm going to be at the door of her house when she gets home. That's a clear and credible threat. Versus, I hate cops. I'm going to shoot a cop one day. That's kind of vague. So really it comes down to clear and credible. You, as novice practitioners, would certainly tell your boss, who would tell their boss about a threat. You may not know if it's clear and credible. You're a new practitioner. You go to the next person in charge. That person goes to the person who runs the unit. They talk to the doctor. They talk to the lawyer, and they make a decision. If you're in doubt, err on the side of caution and go up the chain of command. Patient rights and responsibilities. I think we've gone through this. Psychiatric patients have all the rights of any other person. Okay, we spoke about the rights a few slides back. Patients are not exempt from criminal law. They can be charged with assault. Just because a patient is on a psychiatric unit does not mean that they can hurt somebody and get away with it. In fact, I had a patient threaten me, myself, and my family, saying he was going to murder my family, my children. And, I told him, I said, that's assault. You're threatening me. Well, I'm crazy, so I can get away with it. It doesn't work out that way. Okay? And again, we have to be very careful how we present to the patient, saying that they're still responsible for their behavior. We don't want to provoke them, but we do want to educate them to let them know just because you're on a psychiatric unit does not mean you can harm people and that you will not be charged with a crime. You will be. Okay. Competency to stand trial. Can the person defend themselves? Does the person understand the charges against them? Can they work with a lawyer to defend themselves? If there is a doubt, a judge will order a psychiatric evaluation. It's called forensic psychiatry, where a credentialed nurse practitioner or a psychiatrist credentialed in forensic psychiatry can assess this person to can they defend themselves? Do they understand what the charges are against them? We're going to look at some examples in just a second. Insanity defense, McNaughton rule. Okay, sometimes there's a C after that M. It depends on where you look it up. What is this? State of mind at the time of the crime. Was the person very emotional? Were they psychotic? Things like that. Did patient know he or she was committing a crime? Did patient know right from wrong? Were they unable to control themselves? Was patient psychotic at the time? So what extenuating circumstances was going on with the patient at the time of this crime? For example, you come home early from work and you find your significant other having sex with someone else. You take out your gun and you shoot both of them. You were in such a state of passion and emotion that would be taken into account in a court of law. Insanity defense. But I want to make clear, it doesn't mean you get away with the crime. And the general public, from what I've seen, tends to believe, oh, the insanity defense is ridiculous. People get away with the crime. Oh, no, they don't. And we'll see that in just a second. If person found not guilty because of insanity, they will usually be sent to a psychiatric institution, will stay there until deemed well by the psychiatrist. So you will stay in that institution for the duration of your illness. If you get well, they might discharge you. Well, there was a gentleman named Albert Fentress. I will have you look him up online. I'm not going to go into the story, but you can look it up online. A very interesting case. Guilty but mentally ill. If person is deemed to have known right from wrong or does not meet other criteria for insanity defense, they will be sent to prison and treated while in prison. This was Son of Sam, the .44 caliber killer. Okay, you can look that case up online. Very interesting cases. In fact, up in Goshen, New York, I drive by when I go to my cabin. There is a forensic hospital. It looks built somewhat similar to Pilgrim State, same architecture. With a big barbed wire fence around it, and that is a place for the guilty but mentally ill. And I tend to get advertisements to come work there. Let's talk about nursing liability. Where are nurses apt to get tripped up in liability? Nurses are responsible for providing safe, competent, and ethical care. There are standards of care Standards of care are a set of expectations of what a similarly trained nurse would do in a similar situation. If nurse follows standards of care, which is also called protocol, policy and procedure also, they should not be charged with negligence. If you follow the standards of care and something bad happens, you say, look, I did everything that it says to do, and there was a bad outcome. Well, they have to change the policy. On the other hand, we can have bad outcomes, just like in surgery, in treatment of cancer. Some people don't survive, very sadly. Negligence. Standard of care is not met and patient was measurably harmed. You've neglected, negligence of treating this person properly. Okay? You just ignored the patient. You didn't care for them as you should have. Okay, there was a story where a patient ran away from a hospital, attempted to commit suicide. The hospital staff chased the patient, could not catch him. He was a young man. He attempted to commit suicide on the train tracks. He was hit by the train. He was not killed, but I believe he lost a limb. It went to court. The hospital was not sued because they did everything they could. They followed policy and protocol, but in this case, the person ran quicker than the nurses could run. Gross negligence. This is the most severe form of negligence. Nurse or anybody in medical care willfully neglects duties and patient is harmed. For example, sadly I say this example, willfully not medicating a patient in severe alcohol withdrawal, patient has cardiac arrhythmias and dies. I say this because, sadly, I have seen this. Oh, he's just an alcoholic. He can wait. Oh, he's just a drug addict. He can wait. People coming off of alcohol or benzodiazepines or barbiturates, if they've been habituated to it, can have a seizure, a heart attack, or stroke coming off it. Again, if you look at the biology behind it, but all of those three medicines I just mentioned elevate your GABA. Your body gets used to that. You take away the GABA. You take away the drugs of abuse they were doing. They don't have enough GABA. With not enough GABA, you can have a seizure, stroke, or heart attack. Most cases of negligence or malpractice are handled in civil court, not criminal court. So if you're charged with negligence, you made a mistake, the patient was harmed, you're not going to be charged as a criminal. It will go to civil court. Okay? Now, unless you try to intentionally harm the patient. There was a gentleman, again, you can see it on the screen here, who was injecting patients with a paralyzing drug, and then he would give them the antidote, and the other nurses thought he was a super nurse, just a super nurse. Couldn't believe it. What a great nurse you are. There's another gentleman here. You can read the name. You can look that up also. Okay. Avoiding sexual misconduct charges. Again, when you're working on a psychiatric unit and a patient is emoting to you their deep feelings and you're not judging them, the message the patient may get is, wow, this nurse hears all my dirty, dark secrets and is not afraid of me. My God, she's such a wonderful person. He's such a wonderful person. I'm falling in love with this nurse. Our job is to set up boundaries in the orientation phase of the relationship, that this relationship is professional, okay, therapeutic, not social. It must be made very clear. In fact, I think I've told some of you, particularly the women in the class, if this happens to you a lot, you put on a wedding ring. Okay, I'm married. Please don't bother me. If the patients continue, you say you're married to a cop, and that usually stops their advances right away. Okay, so our job is to set boundaries early in the relationship. We want to avoid being alone with the patient. Never, ever sit on the patient's bed. Never, ever sit on the patient's bed with the patient on the bed. Okay, I've had situations where people, Mike, why don't you come in my room and sit down and talk to me? You can sit here on the bed with me, Mike. Oh, no, Mrs. So-and-so. I will sit by the chair by the door with the door open. You can sit on your bed on the other side of the room and we can talk. We have to make it very clear. Remember, these people are here because there's something going on psychologically, bipolar, depression, schizophrenia. So their judgment could very well be off. Particularly, people in a bipolar manic phase tend to be hypersexual. Okay. We communicate clearly, leaving no room for sexual misinterpretation. Sometimes things can be said where we don't mean it, but someone could misconstrue it as a sexual advance. We have to be very cautious with our words. If you find yourself being attracted to a patient, request that you don't work with that patient. You can just say to the charge nurse, you have lost objectivity. None of us are completely neutral. Okay? All of us have emotions and feelings. Feelings, we generally can't control them. We have to control our behavior, but feelings are very powerful. If you feel yourself being attracted to a patient, you tell the charge nurse, I'm finding it difficult to work with this patient. Can you please give me another patient to replace that patient? Hopefully your charge nurse understands that we're all not neutral. They don't need to know the details of what's going on here, but you have difficulty working with this group of patients. Ways to avoid liability. No state laws concerning profession and area of practice. So you should know the laws governing your profession. Know hospital policy and protocol. Do not make unilateral decisions. For example, if we put a patient on a telephone ban, we don't make that decision. The team does. The doctor is the leader of the team. He takes in information from the nurses, the social worker, the rec therapists, and comes up with a course of action. So we may have to tell the patient that they can't use the phone, but we can tell the patient, I'm only the messenger. I didn't make this decision. You can speak to the team. They're inside of that room right down the hall. Okay. Document accurately but not excessively. We want to document clearly and objectively without emotion, just the facts, nothing but the facts. Clients' welfare always comes first. We are there to help them. We have to establish a therapeutic alliance. When people know that we're on their side, when family members know that we're on their side, God forbid there's a bad outcome and someone dies by suicide, but the family knows that we did our best, we did everything possible, we really tried to work with your loved one, there's going to be less chance of liability there. Never put self in a position where sexual misconduct could be misconstrued by the client, like I said a few slides ago. Okay, I am done here. Thank you. I will post this in a day or two, and some more will be coming. Please study hard, and don't go out in public, and if you do, wear a mask. Bye-bye. Now you see me.